Just going to set the scene for what is Ramadan. A little bit on Ramadan in Australia. Those of you that have heard me give this presentation before, this is essentially the first part of my presentation. I'm going to leave the clinical guidelines to Dr. Mohammed Hassanein, and it's a pleasure to have him here to discuss the recent guidelines, and I really look forward to his talk as well as Sarah's talk with regards to diabetes and pregnancy, which is a very difficult area as well. So, all right, so on this first slide, well, what are these guys doing? Does anyone know?
Looking for the moon.
They're looking for the new moon, the Crescent Moon. So this is actually in Bahrain and sunset, so they're waiting for the new moon. And this is on the left here is in Tehran on the Malad telecommunication tower, and on the right there are some men on top of the mosque there in Basra in Iraq, which you can't actually see. So they're waiting for the new Crescent Moon, which heralds the start of the 9th lunar month, which is the beginning of Ramadan. So fasting is an essential component to many religions. So some of the information we're going to discuss today is also relevant to people from other faiths who fast for a prolonged period of times, but the Islamic holy month of Ramadan is the longest fasting period, and it occurs during the lunar-based 9th month, and its duration is about 29 to 30 days. So it occurs on the same date each year on the lunar calendar, which is 355 days, but the international calendar is obviously longer, 365, so the month of Ramadan moves forward by 11 days per year. So you can imagine that the length of daylight fasting varies depending on where you are in terms of latitude on the globe. For example, it can be up to 16 to 20 hours in the Northern Hemisphere summer, and in 2017, Ramadan commences on May the 27th. So Ramadan is one of the 5 fundamental pillars of Islam. It's compulsory for all healthy Muslims to abstain from pre-dawn to after sunset from eating and drinking, use of oral medications, smoking and sexual intercourse. So just to give you an idea of the typical day, so if you look on the right hand side here, so the start of the fast is usually at sunrise, whereas at sunrise after the pre-dawn breakfast. Now not everyone has a pre-dawn breakfast, which is an important point to ask about in your history when assessing a patient with diabetes in particular, but most people do. And the start of the fast is at sunrise. It goes all the way to sunset, where you're not allowed to eat food or drink, anything for up to 12, from 12 up to 18 hours, depending on where you are in the globe. And then sunset or iftar marks the break of the fast, and it's a period where there's a lot of eating, socializing and prayer, as well as sleep, and that period of sleep will vary between person to person. So the diet during Ramadan is a diet that is often different to what people usually consume in other months of the year. It does vary depending on geographic region, and I'll discuss a little bit about some variations in terms of diet in the Australian Muslim community. So it usually contains a sugar-sweetened beverage and or dates to break the fast, and that's important to understand. Like with any patient we're assessing with diabetes and trying to get a sense for how they're eating and drinking, it's important to understand what happens when people break their fast in Ramadan. So usually it's a date or dates or a sugar-sweetened beverage, which I'll show you some examples of in a moment. Those of you that have driven home or driven through Lakemba or Greenacre towards the end of the fasting period might have noticed that some of the shops set up kiosks out the front and they squeeze fruit juice, and that's how a lot of people will break their fast with a drink because they haven't been having any fluid throughout the day. The food during Ramadan varies, but it's usually a consumption of a large feast of foods. Those of you that have been invited to iftar meals, it's a splendid array of very appetizing and foods rich in a lot of flavour. It's a wonderful meal which goes over a long period of time. There's usually a higher consumption of sweets, so a lot of the Arabic sweet shops, the Lebanese sweet shops in the area will make special sweets during Ramadan, and it's probably the best time of the year if you want to go and eat some Lebanese sweets, go during Ramadan because they're fantastic and there's very high turnover, so they're always extremely fresh. But there's a tendency to overeat with a lot of people and a lot of our patients. Now, in terms of dates are the staple fruit of the Middle East. Those of you that have ventured through the Middle East, visited friends or just gone through shopping centres or even in hotel foyers, you'll often see some coffee and some dates. And it's often served and it's expected to be consumed. And dates are usually what Muslim people break their fast with. It's the food that the Prophet Muhammad ate when he broke from his fast. It's a very good source of fibre and carbohydrates. Does anyone know how many grams of carbohydrate in a date? I've asked this question before. I'm looking straight at you, Robin. You just came in. Our dietitian from Bankstown. So, sorry. 15 grams per date. They must have very big dates. But the size of the dates vary. This is a shop seller in Kuwait. They're beautiful. I love dates. They're fantastic. The average annual consumption of dates in Saudi Arabia is equal to how many kilograms? Trivial question. I've asked this question before. 30 kilograms, about 10 dates per day. So these are the various beverages that are consumed at the break of fast and also other times. So these are beverages that are very intensely sweet. Jalab is very popular throughout the Middle East, and it's based on grape molasses. Tamarind, kharoub is very popular in Egypt and also in other parts of the Middle East, and that's made from carob molasses. And then my favourite, being an apricot lover, Amaruddin, it's based on rolled apricot paste. Intensely sweet, refreshing drinks. You often can't finish it depending how tall the glass is. Now, in terms of the meal, as I mentioned, a splendid array of foods, often very high in carbohydrate and fat, and there's a tendency to overeat, and there's quite a large variety of dishes, and this will vary between communities. So in terms of dietary patterns, this is from the CREED study, which was a retrospective observational look at about 3,000 plus patients across a number of Muslim majority and minority countries. And what I've circled here is 60% of patients responded to say they eat more carbohydrate during Ramadan. 60% above, in the line above, eat larger meals. Up the top there, most people will eat 2 meals, some will only eat 1. This will vary, and you need to ask this in your history. You need to find out when you're adjusting medication. It's very important to find out whether the patients are having that second meal or having 3 meals or 1 meal and what time they're having their meals, especially that meal at suhoor, which is the dawn meal. That's important to ask about when deciding on what to do with medications at that time of the day, sulfonylureas or insulin. Now, in terms of the Australian Muslim community, this is from the 2011 census. 2.2% of Australians, or 476,000 people, identified themselves as Muslim in the 2011 census. I suspect this figure will be higher in the current census, which is being processed at the moment, 2016. I think that data is released in April, from what I could gather. So 2.2% of Australians compared with a quarter of the world population. Now, the Australian Muslims, where do they come from? 43% from the Middle East or North Africa, 18% South or Central Asia, 12% Sub-Saharan Africa. Interestingly, Muslim Australians come from 183 different countries, according to the last census. If you take greater than 1,000 Muslims or more, they are represented by 35 different countries. So it's quite a diverse community, and that's why it's important to not assume a particular dietary pattern during Ramadan. Depending on their ethnicity and culture, they may eat differently in different foods. And that's very important when trying to devise a treatment plan. And the last point here is that the number 2.2%, I thought it was going to be higher. It probably is larger because not everyone will identify their religion when filling out a census form. So in terms of variety in eating patterns in Australian Muslim communities, and I've got to say, a lot of this information I've picked up just by managing patients over the years, and also my dietitian, who currently works overseas, gave me a lot of tips about how different people in different communities will eat during Ramadan. So there's the feast-style iftar meal, which is usually one that occurs at a large gathering of extended family and friends. And there are banquet festivals. I've been fortunate to attend a few in the Middle East when I've been there during Ramadan, and they're wonderful events, plenty of food. The home iftar meal is usually one with the immediate family, 1 to 2 appetizers, a soup, salad or both, a main meal, then fruit and dessert. There are a lot of people who will continue to work and maintain the same sleeping pattern during Ramadan. Often patients who good self-care practices, and they continue to eat 3 meals a day, smaller meals, and take a lot of self-care. I've already mentioned breaking the fast. It's important to know that most people will break their fast with dates or a very intensively sweet sugar-containing beverages, and desserts are common and usually a very important part, sometimes the most important part of the iftar meal. Now, in terms of the Lebanese, Egyptian, Iraqi, Syrian community, the iftar main meal is usually consumed with the fourth prayer of the day at home, the Maghrib prayer. Now, some may go to the mosque for the final prayer, where there's an additional prayer called the Taraweeh prayer, which is not observed by all, but it's a prayer which involves a lot of physical activity, a lot of standing and sitting and prostrating. So there's physical activity involved, and then return home for dessert 2 to 3 hours after the main. And this is what Sarah used to encourage the patients to do, not to have the dessert straight after their large main meal, to spread out the carbohydrate load throughout the evening. In terms of the Bangladeshi patients, their iftar meal may differ to the Arab Australians. The first course usually comprises a combination of fruit, cake, dates, spicy fried chickpeas, fried foods. Then there's the Maghrib prayer, followed by the main meal. Now, the main meal is usually a rice-based meal. That main meal in the Bangladeshi community can occur an hour later. Sometimes it can occur several hours later after the final prayer. So they go out and come back. So these are little bits and pieces of information that's important to ask, especially when trying to help patients fast through Ramadan. They're on medication, you want to adjust their medication. It's important to ask these questions about how they're eating through that non-fasting period. Now, in terms of epidemiology, the estimated population at the moment is 1.6 billion, quarter of the world population. Muslims are growing by 3% per year. Now, the epidemiology of diabetes in Ramadan study, a very extensive epidemiological study that taught us a lot about what people were doing with diabetes during Ramadan. This study was done in 12,000 plus people from 13 Islamic countries. And so 43% of patients fasted during Ramadan with type 1 diabetes, 79% fasted with type 2. That's for at least 15 days of the month. That figure varied depending on which country. For example, type 1 diabetes, the percentage of patients who fasted in Morocco was around 10% versus much higher than 43% in Saudi Arabia. And also there was a variation in the percentage of patients that fasted during Ramadan, depending on which country they came from. So Turkey was quite low, whereas Malaysia, for example, was very high, up around the 80% mark. So studies since the EPIDEMIOLOGY study, the CREED study I've touched on, retrospective observational study in about 3,000 patients, showed that of the patients that fasted, 94% fasted for at least 15 days and 64% fasted every day. Another survey of 39 countries involving over 38,000 Muslims reported that a median of 93% fasted during Ramadan. So a lot of the patients will fast, and we have to accept that, and we have to help the patients reduce their risk of developing complications and assist them in helping them get through the month. Now, my approach when I first started practicing was, if you've got diabetes, how can you fast? It's already hard enough to manage people's hyper and hypoglycemia when they don't fast. So if there's prolonged fasting, you need to discourage people from fasting, apart from those that are on metformin. But that is not the right approach, because most patients will fast, and if you just give them a blanket advice, don't fast, that's it, don't take no for an answer, things are going to go wrong. You've got to help people get through that period. And I've learned over the years that if you raise the issue pre-Ramadan, or certainly if the patient raises it, discuss with them how you're going to help them get through it. And that's going to be what Mohammed's going to talk about later today. In terms of prevalence, diabetes prevalence in Muslim majority nations, so we're all aware of the pandemic of diabetes. This is from the IDF Atlas from 2015. The estimated number of people with diabetes in the Middle East and North Africa is expected to double from 35 to 72 million by 2040. A very large increase is expected also in Southeast Asia, where Islam predominates. And 3 of the top 10 countries in the world with the highest diabetes prevalence rates are located within the Middle East. That's Kuwait, Saudi Arabia and Qatar, 20% prevalence. That's very high prevalence. Bahrain, UAE, Egypt, Oman, Lebanon, they comprise 5 or 6 spots from spot 10 to 20, well above the average global prevalence of 8.8%. And diabetes prevalence also varies between communities in the same country within the Western world. So within Australia, I was involved in a study which we did some years ago now when I was a registrar with Fred Nasser, who's a prominent Lebanese cardiologist here in Sydney, and diabetes 22% versus 7% when we went around and measured glucose levels at various places of worship. And this kind of data has been replicated in other parts of the world, where in Denmark, in Detroit, Michigan, Sweden, where the prevalence is higher for that high-risk community. One thing I've always found unusual in our guidelines, high-risk ethnic groups, those that should be screened for undiagnosed diabetes above the age of 35, subcontinental patients, Indian, Chinese and Pacific Islanders, no mention of Middle East, people of Middle East background. I've never quite understood that. The data is very clear globally and in Western countries, so even in the latest guidelines that came out not long ago, the Middle Eastern population is not mentioned as a group that should be screened regularly for diabetes. And all of you are seeing younger people with diabetes, and I'm seeing a lot of young guys and girls with diabetes in their 20s and 30s, of Middle Eastern background. So in terms of the estimate of Muslims with diabetes who observe Ramadan fasting, so if you do the maths, if there's 148 million Muslims with diabetes across the world, based on the global diabetes prevalence across those countries, we're looking at over 100 million people with diabetes who fast during Ramadan. So it has a major impact on the management of diabetes in the Muslim population around the world, and certainly in Australia, in particular in Sydney, especially where a lot of us work. Now, exemptions from fasting. The Quran exempts the sick or ill from fasting, so diabetes is one of those groups who are exempt. So this is an exemption based on medical and religious recommendation, but as mentioned, most people with diabetes will insist on fasting. And people who miss fasting in some communities are expected to compensate, whether it be by donating to the poor or by fasting at other times of the year. So it's actually also important to note that a lot of people will fast at other times of the year because they're making up for time that they couldn't fast during Ramadan, and also they will fast for other reasons, religious occasions throughout the year. They might fast for 1 or 2 days a week. And again, not a lot of the patients will volunteer that information, and you'll only sometimes be able to glean that when you see somebody on insulin who develops an episode of hypoglycemia outside of the traditional month of Ramadan, and it's because they're fasting. Now, in terms of the risks, I think the risks are pretty clear cut in terms of if you fast. I said earlier, it's hard enough to manage diabetes without prolonged fasting in a lot of patients. So hypoglycemia, hyperglycemia, with or without DKA, dehydration, especially you can imagine with the very long fast this time of the year in the Northern Hemisphere where it's very hot, and thrombosis leading on from dehydration. The EPIDEMIOLOGY study, that extensive epidemiological study I touched on earlier, showed that fasting increased the risk of severe hypoglycemia requiring hospitalisation. This is severe hypos only. There was an increase by 4.7-fold in type 1 and 7.5-fold in type 2 during the month of Ramadan. So hypoglycemia has also been documented in other smaller cohorts of patients. The bottom point there, this was a French study. 27% of patients who experienced hypoglycemia during the day refused to ingest anything orally to correct the hypoglycemia, as it would break their fast. So this is obviously concerning data from that particular patient group, and there are people who don't quite understand that if their sugar drops, they should break their fast with food, with or without fasting during Ramadan. So education is important. Hyperglycemia and DKA was also shown to be higher in the same EPIDEMIOLOGY study. Can everyone hear me? This microphone's a bit short. I just realised I'm far away from it. DKA, patients with type 1 had an increased risk of DKA if their diabetes was poorly controlled before Ramadan. And in fact, in the EPIDEMIOLOGY study, if I remember correctly, it was those patients who adjusted their medication that had more DKA, and that's obviously something that someone's done due to lack of education, and often it's because people reduce their insulin to avoid hypoglycemia and end up developing ketosis or ketoacidosis. So dehydration and thrombosis is a risk. The third point there, increased incidence of retinal vein occlusion during Ramadan in Saudi Arabia. So 30% of all retinal vein thrombosis occlusion occurred during the month of Ramadan in one Saudi Arabian study. Now, as mentioned already, most often the medical recommendation is not to fast. However, many Muslims with diabetes are passionate about fasting, don't perceive themselves as being sick, enjoy the spiritual atmosphere during Ramadan, don't want to miss out on the collective fasting and community spirit created. Particularly, I found in my experience, the female mother patients who are preparing that meal for the rest of the family. It's very important for them to be a part of that iftar meal. And we shouldn't ignore this. We should respect this, and we should assist people in getting through their fasting during the month of Ramadan, even when it appears they're at very high risk of complications. We should try and help them because, as I said, most of the time you give the advice not to fast, they're going to fast. I can recall 2 patients in the last couple of years. One had a stroke and another had coronary artery disease during Ramadan, and both were fasting. So in terms of the risk categories, this is straight from the American Diabetes Association. So there was an expert group of which Mohammed Hassanein was a part of, and they recommended stratifying patients with respect to very high risk, moderate risk and low risk to help decide who can safely fast during Ramadan. So down the bottom there, low risk, so well-controlled diabetes on those agents which do not typically cause hypoglycemia, those patients can fast without medical advice. If you are at moderate risk, second last line there, well-controlled on a sulfonylurea, you should be able to fast safely, but you need to get advice on what to do with your sulfonylurea. The top 2 groups, I'm not going to go through them, they're all high-risk patients. It's quite self-evident that these are patients with characteristics who, if they fast, are most likely going to run into trouble. This was assessed as part of the CREED study, where there was a retrospective observational studies. Physicians were surveyed, and 60% of the physicians referred to guidelines when they gave advice. So the CREED study was done after these guidelines were disseminated in 2005 and then updated in 2010. And it showed 60% of the physicians surveyed, 500 physicians across 12 or 13 countries, referred to these guidelines, used guidelines. Most of them used these guidelines. Interestingly, the difference in fasting days between high and very high risk versus moderate risk was only 2 or 3 days, which means either the patients are not following advice or the healthcare providers are not delivering that advice efficiently. So I'm almost finished. In terms of management, pre-Ramadan medical assessment is ideal, but in reality it doesn't happen because, especially amongst endocrinologists, we're seeing patients at 6 to 12-month intervals. We're seeing them at shorter intervals if they're unstable. We're not often seeing them for that pre-Ramadan medical assessment, but ideally that's what should happen a couple of months before Ramadan. Education's critical, awareness of the risks of fasting. Never assume somebody who fasts for a prolonged period, no matter what religious faith they're from, understands the risks of fasting, which I outlined earlier. Regular self-monitoring of blood glucose levels. Question marks about its validity in certain patient cohorts, but in Ramadan, if people are going to fast, they need to be self-monitoring. And it's important to also remind them that self-monitoring, capillary glucose finger prick, does not constitute breaking the fast. Structured education is something that Mohammed's been involved in overseas very effectively, and it's something that certainly I'm interested in Australia, in Sydney. Medication adjustments, nutritional exercise advice, important part of education. And in terms of structured education, a number of studies published have shown the benefit of structured education. We'll skip past this slide. 2 studies I've highlighted here. 2010, probably easier to look at here. 50% reduction in hypoglycemic events during Ramadan in the group on the left that received the structured education versus those that didn't receive education. You can see there Ramadan hypoglycemic events increased or were a lot higher, 4 times higher during Ramadan than before Ramadan. And there was also a study in Pakistan, a number of other studies which have shown that structured education does help reduce the risk of complications during Ramadan fasting. So I'm going to finish up here to hand over to Sarah Abdu, and I think we're taking questions later.
Marwan, we actually might do some questions in between. So thanks, Marwan, for a great talk. A question, we have time for 2 or 3 questions at least, please. Could you identify yourself and let us know where you're from?
I'm Sarah Bakar, endocrinologist from Melbourne.
Hello, Sarah. Nice to meet you. Yeah.
So I'm a Muslim endocrinologist, and I see a lot of people. So first of all, In regards to the follow-up, I agree with you. When we see patients in private longer-term intervals, I actually find out when Ramadan is happening. So I'm seeing my patients in March. They're already booked to start that process, and I find that works well for me. How do you think the best way is to deliver structured education as a community, not just from a professional point of view, but from the local imams, our diabetes educators, our dietitians? How can we...
Raising awareness. I think there's a lot of ignorance still about the risk of fasting during Ramadan. So we need to mobilise the local religious authorities and group sessions. So with diabetes educator, dietitian, endocrinologist, I think that's going to be most effective, because one-on-one it's great. It works well in the patients who very usually have good insight into diabetes, are motivated. But in reality, when you're busy, and we're very busy in southwest Sydney, it's hard to see all those patients. Often you'll see them after Ramadan, you realise there's a problem, you plan ahead, they may come back, they may not come back. So I think the group education is critical, and that's something that we should be doing in Australia, in Melbourne, where you're from, Sarah, and I know you've been involved in giving these talks as well. And I think we need to get the religious authorities on board, and how that happens, I'm not quite sure, but that's what we need to do. Education awareness days. I mean, we've run them through the Australian Diabetes, Diabetes Council. I've been involved in a couple in the past. Unfortunately, the attendance hasn't been great. They've been run during the week, not for Ramadan. This is just general Arabic community diabetes education. Unfortunately, there's still a feeling that we'll worry about our diabetes when it causes a complication. So the primary prevention aspect is a challenge. It's a real challenge in the communities we're talking about. And the turn-up was good. There were a lot of people there, a lot of older people there, very concerned about their family members. But it's a challenge. There's a job ahead of us to try and mobilise all the relevant people.
There's a question down the back from Dr. Park.
Chris Park from the Penn Hospital. Thank you, Mark. I was just going to ask you, it might be a bit long question to ask, but how much of the diet is actually modifiable? Say, breaking the fast with dates, is that symbolic, religious symbol, so it can't be negotiated, or?
Yeah, I don't usually negotiate the breaking of the fast with dates. I think I don't think the dates, it depends on how many dates you have. I think that's fine. I think it's the sugar-sweetened beverages. Some of those beverages are intensely sweet, so that could be a problem. But in terms of food, there are lots of tips that one can take. Sarah Adama, who used to work with me, used to spend a lot of time getting people to modify their carbohydrate intake, types of carbs, to minimise that post-meal spike. But the dates, look, anything's negotiable, but most people will often break their fast with 1 or 2 dates or more.
And the sweetened beverages, is that a symbolic thing, or is
it varies from culture to culture. It varies from ethnic group to ethnic group. So I guess when everyone else is drinking the same thing, you want to feel part of that collective experience, which is very important for people when they fast. So
artificial sweetener is out of question, then?
Not sure. Not sure. Probably not going to taste as good, I imagine. But
Okay, Sylvia from Westmead.
So just moving on.
Wait, just perhaps with a microphone. Thank you.
Thank you. Just following on about that collective experience, is part of the issue is the fasting, not just the breaking of the fast. So with women who are preparing their family's meal, is the concept of breaking of fasting as well as sharing an experience of eating part of the same process, do you think? The same experience?
Sharing the meal, from my experience, is a very important part of... I understand your question. Look, I'm not sure, but it's the fasting and then breaking the fast with that meal. It's that meal. It signifies the breaking of the fast. It's different to whether it's not the same if you've had lunch or afternoon tea. So that's the impression I've had from a lot of the female patients. And often they'll be they're on insulin, their family's saying, "Mum, you don't have to fast, listen to the doctor." They insist on fasting. Initially, I wouldn't give them a lot of advice in the early days, but I'm now giving advice whether they're giving me a straight up answer, yes or no, because most of them will fast. And you'll know that when they come back 6 months, 3 months later, or whenever you see them next. So you've got to it's imperative to give that advice. It's just some basic advice can go a long way about adjusting insulin, sulfonylurea timings, etc.
Marwan, are there dietitians who are actually particularly versed in, I guess, giving advice or working
There's
with...
a lot of Arabic-speaking dietitians in the last 10, 15 years I've noticed have come up around Sydney. I mean, you know, I had a fantastic one working with me. She's moved overseas, of Muslim background. She was great. But you know, there's a number of dietitians now in Sydney.
While we were having our heavily sweetened drinks at dinner last night, Mohammed told me there's one particular drink which has 1,500 calories. Sudan. So we're seeing a lot of Sudanese now, I guess, as well.
Yeah, the Sudanese community has definitely grown, as you saw from the census numbers, and those numbers will be even more impressive next time.
And many in Sylvia's and Sulin's areas in out west as well.
Yes,
okay.
in the Auburn area.
All right, with that, we've got plenty more time for questions during the day. With that, I've offered Marwan a great deal of thanks and about, I think, 3,000 calories here. Thank you very much for your time. There were no days.